I'm Dr. Rick Greene from the UVA medical class of 1970, and it's my pleasure today to be here to interview Dr. Michael Rein, Emeritus Professor of Medicine at the University of Virginia School of Medicine, for an archives program that we're doing for the Medical Alumni Association. So, Mike, it's a pleasure to have you.
Thank you, sir. It's great to be here.
Let's just start by asking, obviously you've done a lot in your life other than just the University of Virginia, but what brought you to UVA, and give us some insight on that.
Actually, it was my wife's cousin who had been a resident and fellow here, cardiologist, and I was doing part of my training in New York, was in Manhattan, was interested in getting out of Manhattan, and he said, great program at the University of Virginia, you should come down. And by that time, I had decided that I wanted to do infectious diseases. And I met Ed Hook, who was a relatively new chair at that point, and I came down for my PGY3 year.
Well, coming from the Big Apple, obviously, there were certain challenges coming south. Can you share any thoughts when you first got here?
Well, real thoughts. I was much impressed by the closeness between the faculty and the house staff, which I had not experienced in New York or in Boston. And I was also impressed by the house staff being a real team, which was also a little different for me. So I felt very comfortable coming in. In terms of things that were different, I can tell you a story, but it'll use up some of my time. I was a new faculty member, mostly from New York. I'd been in Atlanta for a while. And I had a new fellow who was from Philadelphia. We were called to the emergency room because a patient there had gotten an infection in his leg where a bush hog had thrown a rock at him. Neither of us had any idea what a bush hog was. By the time we got down in the elevator, we had decided relatively arbitrarily that a bush hog was a mammal, that it probably stood about 2 feet tall, and that it defended its nest by throwing rocks. So there was a little bit of a culture shift beyond my being very comfortable here. I certainly hope and expect that over the last 30 plus years that the house staff has continued to feel that closeness with the faculty, which I can't say it's unique, but was really something I appreciated when I first got down here.
Now, I know you've had a lot of involvement with students and house staff. Over the years, what changes have you seen in medical students and house staff, either good or bad? Can you give us any of your thoughts from your perspective?
Well, there are things that I think of both as good and bad, and I will accept the title of curmudgeon at my age. In terms of good, a lot of medical students have done something else before coming to medical school. They are more mature, they have more experience in the real world, and I think that shows in their doctor-patient relationships. I got to tell you, that's tough, at least for the medical students that I've encountered here. They seem to be as dedicated as we were in the remote past. I think they are much saddled with the concept of their debt that most of them will have when they finish medical school. I think that weighs on them, certainly seems to influence career choice or specialty or subspecialty choice.
Let me ask you about that because you gravitated to internal medicine. And infectious disease. What are the things that sort of got you into that specialty?
Well, good question. I left medical school planning to be a cardiologist. I loved my stethoscope, and but I recovered. The patients that I saw during my first 6 months of internship, the ones that just fascinated me the most were infectious disease cases. And so I stayed. The rest is history. It's been a terrific field. There are many things that are unique about it. I'd be delighted to put in a commercial for infectious disease, in this session, but there are several things that are unique. For example, you don't care how my hypertension is being treated, it has no effect on you. But if I'm taking an antibiotic, I have just transferred I'm not, by the way, transferred antibiotic resistant organisms to you. It's the only field where there is direct feedback from the individual to society. Financial feedbacks, all fields, but direct, and we have new diseases. And it's been fascinating ever since.
Well, there's no question. You pick up a paper today, I mean, notwithstanding the Ebola outbreak, you pick up a paper and see that carbapenem-resistant Enterobacteriaceae
Yes.
are involved in some of the endoscopy things we use.
Yes.
I mean, it's ongoing. So there's always going to be a need for infectious disease experts.
One can only hope. We also lose drugs. Other people replace them with better things, but penicillin doesn't do what it used to do. Yes, you're absolutely correct. I consider that one of the best decisions that I ever made and have no regrets about going into that field.
Well, let me ask you, I mean, you could have gone into pure clinical work. You decided to stay in a major academic medical center. What are the things that brought you into academic medicine and kept you here?
Actually, it was not a choice. In my day, if you wanted to do infectious disease full time, you had to be in academic medicine. Now, it worked out great because I love the teaching aspects. The research I wasn't all that good at. So I didn't actually make that as an active decision. After I spent a couple of years at CDC, and after I came back and joined the faculty here, it was a wonderful academic environment, so I stuck with it. Nowadays, lots of people who are trained in infectious disease are going into practice, and HIV/AIDS has a lot to do with that. But it worked out, even though I didn't make that decision actively initially, worked out great for me.
If you had to do it again and medicine was not in the equation, what would you have enjoyed doing in life?
I actually cannot think of an alternative to medicine that would have done for me what medicine has done. However, if forced to choose, I'm going to say architecture. I think it is a field like medicine where one has to know the science, in this case engineering, and you also have to understand people or you cannot be successful. But I'm making that up. I always wanted to be a doctor, and I'm really pleased that I ended up that way.
Well, obviously medicine is not taking 100% of your time. What have you enjoyed doing here at the university in Charlottesville with your family other than medicine?
Well, that was another great decision, was moving to Charlottesville. Fabulous place to live. I must say that when I finished at CDC and was looking at jobs, being from New York and my wife is from Rochester, we sort of thought we'd end up in a major metropolitan area. Came back for, what I thought would be the initial part of my career. Dr. Hook, Dr. Mandel, Dr. Sandy, Dr. Wiebe, Dr. Owen, my colleagues here made it an easy decision to stay. But I have to say, I've always believed that living in Charlottesville is fabulous. There's a lot of educational opportunity. There's a lot of arts going on, and we've always enjoyed those things. Lots of concert series, plays, etc. What is taking up, I'm continuing to lecture, try to stay up in my field, but what is taking some of my time, I'm very pleased about this, is I'm a ham radio operator. And that also is very active and very easy to pursue in Charlottesville.
Let me ask you, I'm a medical student just ready to graduate from the University of Virginia. I'm coming to you for advice, either in your field or in any field. What are you going to tell the young graduate today? You've been involved in students over the years.
I ran the clerkship in medicine for a lot of years, and therefore got to talked to a lot of students, some who were making career decisions, some who'd already decided. And what I would tell them is there is only one reason to be a surgical oncologist, one legitimate reason. And that is if you want to do the things that surgical oncologists do. And the only reason to be an internist is if you want. So what your job is to figure out what you want to do and then set up your career to do it. Now again, we very quickly went over medical school debt, which is a whole other very important issue. But one of the jobs of a medical student is to try to figure out what he or she really, how he or she really wants to spend his or her time. And if you can figure that out, this is good. Now, in terms of academic medicine, I think one of the things that our medical students are well exposed to is what academic medicine is like. And if they've kept their eyes open, they, I think, have good insight into what that involves. Certainly they will rotate with people who are extremely enthusiastic, and they will rotate with people who are less enthusiastic. I happen to like academic medicine because I liked doing all the things that academic physicians were expected to do. Now that expectation has changed. In our day, people were looking for the triple threat academician. My own opinion is that cutting edge research has become so complicated that it's very difficult now to maintain a full clinical regimen, full clinical activity, and stay up in one's field adequately to be a cutting edge researcher as well. Teaching, I think, is easier to incorporate with either of those. So, and I think that academics now have more flexibility than they did when I was first starting out. I was always very appreciative of my division head, Dr. Gerald Mandel, who clearly promoted the triple threat division rather than a division of triple threat individuals. And so with his guidance and support, I was able to focus on clinical activities and teaching rather than having to really focus on all three of those at once. And I think that broadens the opportunities for students who are thinking of going on in academic medicine. They're going to have time to make that decision as they go through residency, of course.
Finally, I want to ask you a little about curriculum changes that you've seen, because this medical school has been, I think, rather advanced in changing curriculum. Give me your thoughts about what that has meant, and would you make any new changes, especially for the young student looking at internal medicine?
Some of the changes I think have been very good. One of them, which is introducing clinical activities into the first couple of years of medical school, absolutely essential. And we did very little of that in my day. We were mostly sitting in dark rooms looking at slides. Because I've been retired for now almost 7 years, I am not as familiar as I should be with the results of curricular change. Much of it, I'm afraid, is not based on a lot of data. And the reason for that is my own opinion. I mean, there are two reasons, there are two goals for medical school, I think. One is to prepare people for residency. Well, we can figure out how well prepared they are very soon. But another one is to make better doctors 15 years down the road. But nobody's doing a prospective 15-year study to see if medical school influences that and in what way. There has been a lot more emphasis in the new curriculum on interactive stuff, and I do lecture in an interactive way to the first-year students now. If I can say this, why they put infectious disease in the first year is not entirely clear to me, but and I think that's probably good. I do know from a number of colleagues who are still active in medical education that the students may be less well prepared to enter the clinics, even though they've had some more clinical exposure in their third year than they were in the past. That's a potential problem.
But if we don't grab the student early in their experience, you as a mentor in infectious disease, we might miss grabbing the student if we wait till the third or fourth year. Maybe that's the reason it should be in the first year.
Well, first year versus second year is what I'm talking about. And, that's a personal opinion. I have no data to support what I've just said either. But we also have expanded the elective time for students so they can experience more things. But you have to accept that A, curmudgeon, and B, I've been away from it sufficiently long that I cannot address the results directly.
Well, thank you for sharing all these wonderful things. We've been talking today with Dr. Michael Rein, Emeritus Professor of Internal Medicine, specializing in infectious disease at the University of Virginia. Mike, thanks so much for being with us.
My pleasure. Thank you very much.